epilepticus. Status epilepticus is one of the most common neurological emergencies, and it requires prompt recognition and rapid intervention. And if we don't do that, we might cause a brain damage.
Thank you so much for that kind introduction. I appreciate you, Dr. Salim, and Dr. Nat, thank you so much for this platform. It is very much needed all around the world, especially in Ethiopia, which happens to be my family's birthplace and a country that's so dear to me. So I'm very much honored to give this talk. So I will start by sharing my screen. Can you guys see my screen?
Yes, you can see
Okay,
it.
perfect. So I will be talking about management of status epilepticus, but this talk will also include some pathophysiology and a few more tidbits about how we go about managing status epilepticus here and where I practice and at Emory University. And I will be asking for y'all's participation to figure out what the resources are available in Ethiopia that you guys currently use for status management. Again, I am Dr. Ebtisam. I'm a general neurologist and epileptologist. I'm an assistant professor of clinical neurology at Medical College of Georgia, and I currently practice at WellStar Health System, which is a joint entity with Medical College of Georgia. Okay. Great. So the outline will be status epilepticus definition and epidemiology, status epilepticus type, management, and identifying etiology. So when does a seizure become status epilepticus, right? That's kind of the question that most of us come across. When do we start calling a seizure status? So there's an isolated seizure, and that seizure will cluster and become an acute repetitive seizure. If we don't abort it, then it goes into status epilepticus. So the general consensus is 5 minutes of seizure is status epilepticus. There's actually a study done by Shiner in 2001 where they looked at a population and they said, there were 407 unprovoked afebrile seizures. 76% of them, the seizures aborted on their own at 3.6 minutes, so before that 5-minute mark. And then the 24% went on to 31 minutes or so before it aborted. So now we know if a seizure goes on past that 7-minute mark, there's greater than 95% chance that that seizure will go on longer than 30 minutes. So early intervention is key. So what is status epilepticus, right? So status epilepticus, again, has a conceptual definition and 2 operational components. So when we say status epilepticus, we're saying there's a failure of mechanism to stop the seizure, or there's initiation of a mechanism that leads to continued seizure activity. So there's T1, which is that where the seizure basically needs to be intervened on. And for each seizure type, that intervention is different, but the general consensus, again, is 5 minutes. And T2 is the time when there is neuronal damage, permanent neuronal damage, right? There'll be a neuronal injury and alteration of neuronal networks. So key point here is status is a special condition, not just a longer seizure, because there's the risk of neuronal damage. So here's the operational dimension that talks about different types of seizures. So there's tonic-clonic seizures, where T1 is that 5 minutes, and then T2 is 30 minutes. So if we don't abort that seizure by the 30-minute mark, we're causing long-term consequences, which we don't want for any of our patients. And focal status with impaired consciousness, this one, the T1 begins at 10 minutes, and then the permanent long-term, maybe not permanent, but the prolonged long-term consequences will start occurring at that 60 minutes or so. For absence seizures or absence status epilepticus, we don't really know where the T2 starts. Basically, again, the point is we need to treat seizures as quickly as possible, and we need to abort them. Okay, so now we talked about the general sense of what status epilepticus is. You know, there's difficulty in terminating the seizure or there's increased propensity for the seizures to occur. And then we talked about what T1 is, what T2 is. But we have other parts of status, right? Refractory status epilepticus are those that we can't control by first-line treatment, which is benzo, or second-line drugs. And supra-refractory status epilepticus is when we have to, this is not controlled even by third-line agents. So these patients will continue to seize despite us putting them on medications like propofol, Versed, and etc., and even ketamine. This talks about some of the mortality rates and percent of status epilepticus cases that we see for different disease processes. And this is a study, it's in neurology, and it's by Di Lorenzo, and it was done in 1996. It's a really good paper if you guys have time to read it. But it talks about how anoxia is one of those that cause the highest mortality rate when patients end up with status epilepticus and have anoxia. And then the one that has the least mortality rate, but is one of the ones that we could potentially avoid is low anti-epileptic drug, right? Those patients that have subtherapeutic levels of medications. Their mortality rate is low, and these are the ones that we could potentially intervene on by making sure that their medications are therapeutic at all times. And other causes of epilepsy are, as we all know, it could be metabolic, CNS infections, tumors, trauma, remote injuries, and sometimes we just don't know why someone has a seizure. So factors that impact our outcome, meaning when we start treating a patient, what are some of the reasons that one patient doesn't respond better than another? It could be the age of the patient, right? It could be the etiology, what caused the seizure to begin with, and also the duration. The longer we leave a seizure going on, the harder it gets to treat that seizure. Now we spoke about what status epilepticus is, the definition, and how rampant it is, and how some disease processes tend to cause, if there's a seizure associated with it, how the mortality rate is higher, for example, like anoxia. And now I want to just focus on the different status epilepticus types. So status epilepticus has 4 axes. What I mean by that is there's the semiology, the etiology, the EEG correlate, and the age, right? So semiology is, what is the seizure like? When a patient comes in, what are they doing? That tells us that they're having a seizure. So convulsive is the one that we all know about, tonic-clonic. Focal motor could be impaired or unimpaired, where the patient is aware of what's going on and half of their body is actively having a tonic or a clonic movement. And the non-convulsive status is these patients may be comatose or they may be awake and having a seizure. And the etiology could be an acute trauma, like they've had a brain bleed, or it could be something remote, like they've had a prior stroke. And we have to, if I know it's hard in the country that we're in, Ethiopia, to get EEGs readily, but also knowing on the EEG, the location, the type of pattern, the morphology kind of helps us to determine how aggressive we need to be in treatment. And also the age of the patient, the medications we use in a neonate versus an elderly patient is very different. Okay, so we talked about status. We know what status is now, and we know we have to treat it as quickly as possible. So with status, there's two different entities, right? 2 types of classifications. Those with prominent motor symptoms, which most of us have seen in our practice, and then the ones with without prominent motor symptoms. So by that we mean you don't actively see them seizing or moving and having outwardly body movements. So with prominent motor symptoms, we have convulsive status epilepticus, myoclonic status epilepticus, and focal motor status epilepticus. And I won't go in detail, but without prominent motor symptoms, again, we have convulsive status with coma, and then the one without coma, right? And without coma, it could be generalized if you have the ability to look at their EEG. Their pattern is throughout all the fields, where focal could be in just, it could be in the temporal, parietal, left, right, occipital, kind of like that. And with absence status epilepticus, this is the one where we know we have to like treat them within that 10 to 15 minutes. That's their T1, but we don't know where the T2 is. So the consensus is, again, treat as quickly as you can and abort the seizure to prevent long-term consequences. This is such a busy slide, but I think it's very important, especially since this is going to be recorded. You guys will have the opportunity to go back and look at it. And what it shows us is the semiology, meaning what the seizure looks like and the level of consciousness, can actually determine the degree of case fatality. Meaning, if a patient comes in with status epilepticus and they have prominent motor phenomenon, the ones that I talked about, focal motor, generalized convulsive status, things like that, if their case fatality is about 10.3%, which is less than those without prominent motor symptoms. And I'll kind of go in detail a little bit here. So the highest that we see in status epilepticus with motor phenomenon is in those patients who have somnolence, stupor, or coma. So if our patients are heading in that direction where they're becoming comatose, we can't arouse them, then their case fatality is going up, right? Here it shows us there's 40% in those who come in with non-convulsive. It evolves to focal motor tonic or myoclonic. And if they go to somnolence, it goes up to 40%, where if they were fully awake with reduced consciousness, the case fatality was only 0%. That's huge. And then when we look at our patients without prominent motor phenomenon, again, the number that they used, right, is only 76 patients, but we can extrapolate data from that. Their case fatality is 27.6. So if they come in with non-convulsive and they're somnolent, and they become more somnolent, their case fatality goes up to 41%, right? And let's look at here. If they come in focal motor tonic or myoclonic, evolving to non-convulsive, right? And then they become stupor, that's 60%. So let's intervene as much as we can before our patients get into a stupor comatose state to avoid long-term consequences for our patients. Uh-oh, 1 second. Okay, good. It's not letting me advance. Give me a second. Okay, good. So the take-home point here is all status epilepticus is not equal. T1 and T2 likely varies based on the semiology and etiology of status epilepticus. Semiology and etiology can both be helpful in classifying mortality. Three determinants of outcome again are the age, the etiology, the duration, right? Use semiology and etiology to guide aggressiveness of management and workup. When a patient is fully awake, you may not need to be as aggressive as when they're comatose. But again, if you don't intervene as soon as possible in those patients that are awake, again, they may go ahead and enter that comatose state and increase their case fatalities. Mhm. For some reason, my presentation wants to not advance. So again, give me a second here. 1 second.
Should I make you a co-host again?
You're fine. I just need to fix something here. Give me 1 second.
It's okay.
Okay. I just needed to minimize it. I apologize. Okay, so we talked about the take-home points here, and then now we'll go one by one. We talked about status epilepticus definition and epidemiology, status epilepticus type. Now we'll talk about management. Good. Okay, perfect. So here as another busy slide, I'm sure you guys love these busy slides as much as I do, right? I'm being sarcastic, but I think it's very important to look at these slides and kind of understand what goes on in metabolically, and also what is the neurophysiology behind what happens in status. So acute seizure, right? We talked about how there's difficulty in terminating the seizure, or there's properties that increase the propensity for seizure. So neurophysiologically, what happens is there's a decrease in GABA and there's an increase in NMDA receptors. So now what our body does is it tries to come up with compensatory phases to help us battle the seizure. So what it does is there'll be increased cardiac output, blood pressure, blood glucose, blood lactate, because we're just actively working and aborting the seizure. Our bodies normally do that, and they're successful most of the time because the seizures usually abort within 3.6 minutes. But if they're not, then there'll be decompensation that leads to decreased cerebral blood flow. And if there's decreased cerebral blood flow, there's decrease in brain tissue oxygenation, which means there'll be brain tissue injury. In addition, there'll be there'll be failure in cardiorespiratory collapse. There'll be electrolyte imbalance, rhabdo, tubular necrosis, multiple organ failure. I mean, you name it. If we don't intervene at that 5-minute mark, we're putting ourselves at risk for decompensation in the hemostatic failure. And if that goes on, then we're really putting ourselves in a huge predicament, causing multi-organ damage. So I will leave this here for you guys to look at. So acute seizure, then early status epilepticus, refractory status epilepticus, and the last one is the malignant status epilepticus. That's when, if you look at the neurophysiology aspect of it, there's altered gene expression. Now we don't even know if these receptors are actually present and visible for us to even administer medications, right? That's why the longer the seizure goes, the harder it is to treat. There's electromechanical dissociation, meaning like these patients are pretty much comatose at this stage when we get to malignant status epilepticus. And it does a good point here where it talks about brain damage and puts the marks at 0, 5, 30, and 60 minutes. So when you have time outside of this presentation, definitely look at this study was done in 2011, Foreman and Hirsch, it's a neurology clinical aspects. Okay, so this is kind of a shortened version of that big chart or diagram I showed you guys. So the pathophysiology, again, is failure of mechanisms that normally abort seizures. So what's that excessive excitation? Again, it's in the glutamate and excitatory amino acids, neurotransmitters, and NMDA receptor upregulation. And then what is being decreased, or the inhibition that occurs, is, again, there's low GABA, and sensitivity and number of the GABA A receptors is low. So that's why benzos work in acute status, because they're really working on those GABA receptors. So management of status epilepticus. So now this is the kind of the meat of the presentation. So how we manage status is we have to stabilize the patient first. Airway, breathing, circulation. We need to administer medications as quickly as possible, and then identify and treat the etiology. So initial stabilization, right? Like I mentioned, airway, breathing, circulation, it's a medical emergency. Dr. Salem mentioned that earlier. So give them oxygen if they need oxygen, intubate them if they need to be intubated, resuscitate them if they need to be resuscitated. At the same time, make sure you get a finger stick glucose. Is it less than 60? If so, give them some thiamine, give them some D5W. Check their electrolytes, do a tox screen. If they have history of epilepsy and they are taking anti-seizure medications, check those. And if they're women, make sure you get a pregnancy test. And when you're able to stabilize them, give them benzo, and their seizure have subsided, then you can go ahead and try to get a CT scan, a focused history, and all those good things that help us manage our patients appropriately. So again, history of seizures. This has a great prognosis, meaning if a patient has seizures and then they come in with seizures, you treat them as quickly as possible, their mortality rate is very, very low. Versus a patient that comes in unknown, we don't know why they have a seizure, they've never had a seizure, we scan them, we don't see anything, their mortality rate is higher. And then try to find out, are there any provoking factors? Were they drinking? Did they stop drinking? Were they exposed to some toxins? Are their electrolytes completely off? And also, is this a new onset epilepsy? Have they had strokes in the past? Have they had tumors that were resected? Those would help us kind of figure out and triage our patients as quickly as possible. So convulsive status epilepticus, early treatment. Give me 1 second here. So early treatment is most effective. And unfortunately, we only have data, evidence-based guidelines for generalized convulsive status epilepticus. So we are actually, as physicians, extrapolating data from generalized convulsive status epilepticus to treat the plethora of seizure semiologies, right? From focal motor, from absence, myoclonic, non-convulsive, we're using the data that we have from generalized convulsive status epilepticus. So the first line of treatment, again, benzo, benzo, benzo. So it's rapid onset, but it needs IV access. So if you're doing this, hospital is the best choice. But if it's outside of the hospital, here our EMS and emergency medical services carry midazolam, which they can administer IM intramuscular, and that works very well. And then for outside of the hospital, for our kids, pediatricians prescribe diazepam, which you could administer rectally. So there was this study done in a pediatric population where they said, okay, so we want to see how quickly we're administering benzos, and then looking at how what the mortality rate is, and also if we administer medication quickly, do we need to use continuous IV infusions? And as you all may have guessed already, if you treat within that 5-minute period, like as soon as that 5-minute hit, great, you're doing amazing. If you actually also treat within the 10 minutes, then the risk of death in these patients was 0%. And then the need for continuous IV infusion was 43%. But if you let it past that 10 minutes, there was a 4% risk of death, and then 71.4% for need for continuous IV infusion. This is all to just like say, hey, we need to treat, we need to treat. But in a place like Ethiopia, I know resources are limited. And I was talking to Dr. Aganet, and she was telling me kind of what we do is basically we try to intervene in Ethiopia as quickly as possible, but in most cases, the patient sees maybe the aborts on its own, and then when we're able, awake enough, then they get their anti-seizure medications. And I hope there will be one day that we can all have a standard of care and resources readily available. But, that's why we have ENNOT and CareEpilepsy and all of you here to hopefully change the paradigm of the treatment of epilepsy in Ethiopia. So this is another study where they looked at IV lorazepam versus IV diazepam. Because you're like, why wouldn't it work, right? It should work, but IV lorazepam, again, is superior to IV diazepam. There's a 59.1% superiority compared to 42.6%. So if the patients are able to be treated, IV lorazepam works best. In the hospital, it's readily available, quick bioavailability. However, if you're out and about outside of the hospital, what works best is IM midazolam. And they did a study called Rapid Anticonvulsant Medication prior to arrival to the emergency room, I believe, arrival to treatment or to a facility. In this case, what was more superior in efficacy was IM midazolam. So 10 milligram of IM midazolam was more efficacious than 4 milligrams of IV lorazepam. And again, you wonder why would IM midazolam be better than IV lorazepam? Well, very simple. It's just how quickly they can administer it. They can administer IM medication at 1.2 minutes versus the IV, which they would have to pull the syringe and things like that. That would have taken 4.8 minutes. So another great study to show early administration is better. So this is the dosing that is used for lorazepam, midazolam, and diazepam. For lorazepam, it's 0.1 milligram per kilogram. You can give up to 4 milligrams, and you may repeat the dose in 5 to 10 minutes. For midazolam, it's 10 milligram IM, and hopefully you'll get them to a facility as quickly as possible. Diazepam, again, this is given to children rectally. It is 0.15 to 0.2 milligram per kilogram, or you can just do a max of 10 milligram dose. You can do, and there's a few studies out there that compare superiority. So take home point number 2, status epilepticus, yes, we all agree is a medical emergency, and keep status epilepticus in the differential, in your differential early so you can treat early. Time is brain, we know that. And stroke and seizures, we know it. Delayed or underdose treatment is linked to increase in mortality and need for continuous IV infusions. So what are our second-line anti-seizure drugs or anti-seizure medications? Here we have 5 IV anti-seizure medications: fosphenytoin, valproic, levetiracetam, lacosamide, phenobarbital. There was an ESET trial which basically compared these and said they all work very well, use them as quickly as possible. And then there was a meta-analysis looking at all the different studies that were done that said, oh, wow, valproic acid is more superior than these other medications. But again, do I always go and get valproic acid for my patients or go for our levetiracetam, which is Keppra, or do I go to lacosamide, which is Vimpat? No, I have to know my patients and I have to know their comorbidities. So if a patient comes in who has liver failure and has thrombocytopenia, then I wouldn't be using valproic acid because then I'm just worsening their underlying condition. If a patient comes in who's psychotic, and I know Keppra causes psychosis, suicidal ideation, that wouldn't be the medications I would go for. And if I know a patient has already a PR interval prolongation as have cardiac arrhythmia, Vimpat or lacosamide wouldn't be the medication I go for. So know your patients, uh, know their comorbidities, and give medication based on those criterias because they all work well as long as they're given early. So this is another paper that kind of compared all of these. And what happened, again, I said valproic acid, which is the VPA, valproic acid, is superior. So for valproic acid, there were 9 papers that they looked at. They had 251 patients. The efficacy was 75.7% compared to, for example, phenytoin or phosphonatoin, which was 50.2. So based on meta-analysis, we know valproic acid and phenobarbital work well, but phenobarbital has so many adverse side effects. So we tend not to use that unless we're in that supra-refractory status category. Another meta-analysis that looked at the second-line anti-seizure medications, which are the 5 ones that we have in IV form: phenobarbital, valproic acid, Keppra, phosphonatoin, and Vimpat. And when we look at that again, we found out phenobarbital and valproic acid are the most effective, but the one that's most cost effective was levetiracetam, which is Keppra. I personally really like Keppra. I tend to load my patients with that when they come in with status because I don't have to worry about a lot of side effects, and I don't have to worry about renally dosing it. And again, for all these medications, you don't have to worry about renally dosing them when you're loading. So Status Epilepticus, trial in 2013, they looked at if you give benzo at the 0.1 milligram per kilogram, 4 milligram max, and then you repeat it again in 5 to 10 minutes and your patients are still seizing, then you need to go to the second line drugs, right? So phenytoin here, what we do is we load with 20 milligrams per kilogram and up to 1,500 milligram over 10 minutes. For valproic, we do 40 milligrams per kilogram up to 3,000 milligrams over 10 minutes. And Keppra, like I said, I really like levetiracetam. I really like Keppra. You can go 60 milligram per kilogram up to 4,500, which is 4,500 over 10 minutes. So that's kind of the dosing that we utilize here. This is another point. Pick the drug that's safest and easiest to give rapidly. Okay? Phosphonatoin, just looking at it here without going in detail, as you can see, levetiracetam Keppra has the shortest side effect profile compared to valproic, which is higher, and phosphonatoin, which is in the middle. If we had phenobarbital, it would be way longer. So I know Inath has been trying to get and again, this was telling me that we're trying to get as much Keppra into the country. There's been some difficulties there, but again, this is not the platform to talk about that, but to say if we can get our hands on Keppra, great. Phosphonatoin works very well as valproic acid. They're all really great medications. So this is the protocol that we use at Emory, where I trained, and I think it's really very effective, and we've been using this and I started training in 2015 there, and I was there until 2020. That's when I finished my epilepsy training. And this was implemented in 2018, and we saw a lot of improvement in outcomes for our patients who come in with status epilepticus. So time is everything, right? Time is brain. So there's a time here from 0 to 10 minutes, 10 to 30 minutes, and 30 to 60 minutes. So in the 0 to 10 minutes, we're literally trying to stabilize the patient. airway, breathing, circulation. We're obtaining IV access. We're checking the blood glucose. We're monitoring vitals, getting labs, and giving our IV lorazepam 0.1 milligram per kilogram, 4 milligram IV push over 2 minutes. If they don't stop seizing, we're giving another one. And then if we're having a hard time getting IV access, then we're doing IM midazolam. You can do 10 milligrams for weight, which are for patients that are less than 40 kilograms. For those above 40, you can give 10. Then if they're still seizing, we're in that 10 to 30 minutes. We don't want to get to that T2 time frame where we cause neuronal damage. So we're looking at choosing one of these anti-seizure medications. There's IV fosphenytoin, which is 20 milligram per kilogram. Keppra, 60 milligrams per kilogram. Valproic acid is 40 milligrams per kilogram. And then lacosamide, which is a wonderful drug as well, is 400 milligram. At this time in our hospital, we're trying to determine, do we need to put these patients on continuous EEG? And the way we determine that is if the patient doesn't wake up shortly after administering these medications, then we're concerned that these patients are going into non-convulsive status epilepticus. We don't know. We don't want to cause increased case fatalities. So we go to our third line treatment, which is the anesthetics medications, in that 30 to 60 if the patients are still seizing. And we have midazolam, propofol, ketamine, and pentobarbital, which we use. I will not go in detail about those, but pretty much treatment-wise, the goal is seizure suppression. So you want to stop the seizures. And this is the protocol that we used at Emory where I trained. Dr. Salim, uh, what protocol, when I talked to Dr. Zaganet, she was saying how basically we treat these patients, they end up seizing, we try to intervene as quickly as we can, but mostly is once they are able to take their meds is when we administer it. What IV medications do we have in Ethiopia that we can give?
So the IV medications that we have here is mostly diazepam and
Mm-hmm,
sometimes lorazepam, but the
mm-hmm.
others are not available.
Yeah, that's kind of
Anyone
what
that
she.
can add any more, any participant that can add any more, you're welcome.
Yeah, feel free to tell me what we have in Ethiopia, so we could come up with a seizure management of status epilepticus in Ethiopia, right? This is a presentation geared to treating
You can
Ethiopian.
write your answers. Okay,
Yeah,
IV phenytoin is available at times. Dr.
IV
Fanwell said
phenytoin.
that.
Oh, that's great. So IV phenytoin works very well. It has its downsides. You need to make sure these patients are not hypotensive because it tends to potentiate that. And make sure that you're not infusing it too quickly. You could end up causing Redmond syndrome and things like that. But it's a really good drug and it works very well. So I think if we were to come up with a management of status epilepticus in Ethiopia, would be using IV diazepam, IV lorazepam, and from the diazepam standpoint, we can administer a 0.125 to 0.2 milligram per kilogram to a max dose of 10 milligrams. So that's one option. And then as the patients, if we're able to administer these oral meds, administer them as quickly as you can. Uh, one way of doing that is, if possible, putting an NG tube or a Dopolf like through the nose to basically give the medications. Uh, but yeah, thank you. So fosphenytoin, like I mentioned, is a sodium channel blocker. It can be administered IV or IM. IM is not ideal. It can cause hypotension, arrhythmia, transient pruritus. Advantages of fosphenytoin over phenytoin is it's water soluble, so it's 3 times faster lower incidence of cardiac arrhythmias and hypotensions, lower incidence of purple glove syndrome. I'm sorry, purple glove. I think I said Redmond syndrome. Purple glove syndrome. Weight-based dosing, 20 milligram per kilogram. And then we have valproic acid. Again, really such a great drug with side effects that we need to keep in my mind. Um, it acts on multiple channels, GABA, NMDA, histone deacetylase inhibition. It has its broad spectrum based on the meta-analysis, and compared to all five, it's superior. And side effects, again, dizziness, hepatotoxicity, thrombocytopenia, hyperammonemia. So if you're, I would really avoid it in patients with liver failures and alcoholics and things like that. Load it to load 40 milligrams per kilogram, and you can always give a partial load here. And then lacosamide is Vimpat, which is actually a very good medication. It basically works on the sodium channel blocker, similar to phosphonatoin, but prolongs slow inactivation of these sodium channels. Side effect wise, you need to make sure that these patients don't have PR prolongation because it can worsen that gap. Keppra is one of those that we're using so much in my practice. It works on the SV2A inhibitor. It's rapidly acting, minimal interaction. I mean, basically, if someone is psychotic, it can make them psychotic. But other than that, it can cause some sedation and delirium. And you can give such a high dose, 60 milligram per kilogram. Phenobarbital, we do have phenobarbital in Ethiopia in the IV form, correct?
I don't think there is.
You, oh, really? Okay. Since phenobarbital is such an old medication, I assumed, but I know there we do have the oral, correct?
Yeah, it is
Yeah,
available.
we have oral. Okay. So this one too is we try to avoid it because of the plethora of side effects, but if this is all we have, it works very well based on the ESAP trial. All of them are effective. So this one, best evidence pooled, when we look at all the evidence, there's a 73.6% of efficacy, and it's a low cost compared to all of them. So this medication is one that could be potentially uh, administered given the cost from a cost basis. But side effect wise, you need to make sure that these patients are not on medications that are already cytochrome P450 inducers. It can cause hypotension and respiratory depression. So these patients have to be monitored. You don't want to be the reason these patients are intubated. So refractory status epilepticus. So this is, the acute phase. We gave our benzo, we gave our second line. Now our patient is still seizing. You're like, oh gosh, I don't want these patients to have neuronal damage. And that's when we basically go on to use our anesthetic medications. So refractory status epilepticus, convulsive status. If it's convulsive status, you need to rapidly initiate anesthetic meds. If it's non-convulsive status plus coma, trial of, again, you can retry these oral IV meds again. If it's not effective, initiate your anti-anesthetic medications. Again, you can always consider oral partial IV phenobarbital load. Clobazam is one of those medications. The other name for it is Onfi. It only comes in an oral form. It is a component is similar to benzone. It's very effective in treatment of these patients with refractory status epilepticus. This is it's a great slide. I am not going to go over it for the sake of time, but when you guys have time, please take a look because it talks about the mechanism of action of these medications. For example, Keppra, it works on the SV2A. Phenytoin, carbamazepine, oxcarbazepine, they work on the voltage-gated sodium channels. Again, lacosamide, it talks about gabapentin, pregabalin, where they work. And it talks about, from a neurotransmitter standpoint, what these medications are doing. So we said seizures happen or status happens because there's lack of termination or increased initiation of seizure. So by knowing how that happens, which is the GABAs and the NMDAs, we're able to interfere better. Valproic, what it does is increase the GABA turnover, and we know decreased GABA activation is one that potentiates seizures. And topiramate is look at that as well. So really great side, but too busy. I tend to do that sometimes. Okay, refractory status epilepticus, we talked about it. You're going to use your anesthetics. Midazolam is a great one, propofol, thiopental, ketamine, phenobarbital, you can use any of them. So how we put our patients on these IV medications, and then now we're completely sedating them. And we don't know, how do we know how far to go with these anesthetics? One way of determining how much we need to treat is if we have a continuous EEG. And I'm well aware about the limitations of EEGs in Ethiopia. So what we do here is basically the goal when we're treating these patients with epilepsy is, or refractory status epilepticus that we end up putting on anesthetics, is saying, okay, we're not trying to burst suppress them, meaning when you look at your EEG and you have all your patterns there, we're not trying to basically cause a flat line, right? What we're trying to do is to make sure we suppress the seizure. We don't want to see that many seizures. You could have breakthrough seizures. When that happens, you bolus them. Again, you have to be willing to let some seizures go, because you have to keep in mind as you're giving more medications, you're overloading the system as well. So having an EEG is very important for that. So once you suppress the seizures, you'll see, are they seizure free for 24 hours? Then you start weaning down the medications, the IV medications, the anesthetics, mainly the propofols, the Verseds and things. And at the same time, you'll start increasing your oral meds or IV anti-seizure medications, the valproics, the Keppras, the Vimpats, and things like that. You increase the dose there. Then finally, you'll start kind of saying, okay, these patients are seizure free, and you'll continue to reduce your anesthetic use. So identifying an etiology. That's like kind of my last portion of this presentation. So if you guys have questions, start thinking about them so I can answer before the end of our talk. So identify and treat the underlying cause. That's always key, right? If someone is having a seizure and they've already have history of epilepsy and they're on anti-seizure medications, I think the first thing is, hey, how often are you taking your medication? Have you missed any doses? Get levels if you can. And then did the patient come in with a stroke? Do they have a brain infection? Do they have meningitis? One of the main causes of seizures in places like Ethiopia. And also, does someone have a tumor? Are they using illicit drugs? Are they alcoholics? Are they in withdrawal? And we do all of that, and then we come across patients who have new onset refractory status epilepticus, NORS, which in the US accounts for 26 to 50% of our patients. And these ones are super difficult to treat because you don't have any etiology, you don't know why it's happening. And we actually use after we rule out infection, we do a lumbar puncture, no meningitis, we get MRIs, there's no tumor, there's no blood, there's nothing there. We're continuing the IV, the anesthetic medications. Then we say, hey, like, how about we give them immunotherapy or just even high dose steroids? So we do Solumedrol, 1,000 mg per day for 3 to 5 days. So that has been used as a treatment modality as well. So NORS, again, a clinical presentation in patients without active epilepsy or other pre-existing relevant neurological disorders with new onset of refractory status epilepticus, again, without clear or acute structural or toxic or metabolic causes, which can be identified within 72 hours. It's unexplained, it's explosive, usually refractory to anti-seizure drugs. So one of the things we need to think about in these situations is encephalitis, and there's a lot of autoimmune encephalitis now. So doing a lumbar puncture here is, we do it all the time in patients that come in with these refractory epilepsies. We do get our imaging. There's even cases where I've personally never ordered a PET scan to look for hypo or hypermetabolism, but some institutions do that. I'm sure Mayo does that as well, to just look for any increased or decreased metabolism in the areas where we assume the seizures are coming from. And you also want to do a malignancy check to see if these patients have some kind of paraneoplastic process going on. And in this case, in our patients with refractory status or super refractory status, we implement the kitchen sink method. Literally means throw everything at them. Do whatever you can. Give them all the medications that are out there. Do your steroids, your IV immunoglobulins. Sometimes we do plasma exchange. We put feeding tubes to start giving the medications that don't come in IV formulations, like topiramate, gabapentin, Onfi, clobazam. I've never used Epidiolex in these cases, but that's one that you could potentially use. And then I'm sure you've heard of ketogenic diet, which basically these patients are deprived of anything carb and given fat. And the idea is you're depriving the glucose, which could reduce the risk of prolonged seizures. And they use it a lot in the pediatric population. And also when there's a lesion that you can go after, surgeons can go ahead and resect them. And I think we should probably, I don't know how important or useful this talk would be, but neurostimulators are some things that we use in the US, and those are like vagal nerve stimulators, deep brain stimulation, RNS, response neurotransmitter therapies, and electroconvulsive therapies and things like that. So yeah, when these patients come in with refractory status or super refractory status, we use the kitchen sink method, meaning we just give them whatever we have. We all like cases, I'm sure. So this is a case that I would like everyone's participation on. Give me 1 second. Let me move this over here. Okay, so this is a 29-year-old female who comes to the ED. She had a generalized tonic-clonic seizure after consuming alcohol at a party. EMS gets there. They give her 10 milligrams of IM midazolam. She remains unresponsive. Okay, so they brought her to the emergency room. She has history of epilepsy since the age of 8. She takes Keppra 1500 milligram twice a day. She's allergic to lamotrigine. Her most recent seizure was a year ago. They gave her phosphonatoin IV and the seizure aborted. She was seen in epilepsy clinic and her Keppra level was therapeutic. She does have alcohol dependency issues, but her seizures haven't been related to alcohol withdrawal. In the ED, she comes in, she has multiple seizures again, lasting 5 to 10 minutes. They did give her benzos, but they weren't able to abort it. Her vitals are pretty good. As you could see, her blood pressure is 148 over 94. Pulse looks good. She was hypoxic initially, so they did put her on high flow oxygen, and she's 98 right now. Lab wise, blood alcohol level was high, but the rest were unremarkable. So if you were to treat this patient, would you go with phosphonatoin, with Keppra 1 gram, Keppra 4 gram, valproic acid load, or another anti-seizure medication? You can just put your answers in the chat box if you want.
Everyone, please participate. Write your answers in the chat box if you know the answer.
If you want
So,
to. You don't have to.
mm, so we have an answer until now. Ahmed
Okay,
said
great. Ahmed
it was
says
painful.
A.
Yeah.
And then I also want to take this opportunity where when you guys are answering this question, uh, Fanwell was saying, what do I think of using paradoxin to treat refractory epilepsy? Okay, great one. So I haven't used it in the adult population. We have used it in the pediatric population, but it's more of an adjunct therapy, meaning you've used your IV, your benzos, your IV medications that are available to you. In addition to that, you can add paradoxin. A lot of the study shows it's not as effective as we would hope, but if that's all we have, then absolutely go for it. Okay, so I think I will go ahead and say yes, I agree with Ahmed. The answer is phosphonatoin. And the reason is very simple here. Like, she's already on Keppra. We know she's therapeutic from her recent visit with the neurologist. And most of all, we know that she was phosphonatoin worked in the past. So if it works, if it ain't broke, don't fix it. If it works, use it. So that's why we're going to use the phosphinatone here. But I want to, okay. So I still want to drill down this very important topic to say that you, all the anti-seizure IV anti-seizure medications available based on the ESAT trial functioned about the same. Based on the meta-analysis, we know valproic acid is superior. However, you want to pick the medication based on the patient's morbidity and mortality and co-founding factors. So for this patient, phosphonatone is probably a good option because of better for focal epilepsy. It may aggravate generalized epilepsy. She had good previous response to it. She's familiar. And then valproic acid is a great one as well, which we're avoiding in this patient because of her ETOH dependency, but has also, she's a woman. We haven't done a drug pregnancy test, so I would probably not use valproic acid because it has a high teratogenicity risks. And Keppra, I love it. I love this drug very much, but she's already on it and it's therapeutic. And then my conclusion here is, you see how this picture kind of depicts what goes on in a patient with status. It's chaos, real chaos. I think she's looking for something small there, but ended up destroying her home. So in status, we don't want to destroy the home. We want to start treating as quickly as possible to avoid long-term consequences. Patients with refractory generalized convulsive status epilepticus or continuation of the generalized convulsive status epilepticus need to be treated aggressively. All of them should be. If you have EEG, great. Use it for the refractory status epilepticus. We don't have that much study that talks about other therapeutic modalities, but we are good about extrapolating data. So the data that we have for the generalized convulsive status, we're using for all types of seizures. And in the meantime, dose very well, minimize treatment delays, and identify and treat the etiology. When considering therapeutic coma, consider the etiology, neuronal activity, their seizure burden, and then if you can get them at 10 ICU, as quickly as you can, do that where they'll be monitored closely. Do you have any questions? If you do, feel free to ask me now. If you don't have any questions right now, feel free to take my phone number, my email address, and send me questions or anything that you may need. If I'm able to, I will help.
Okay, so until now we have one question. You can read it from Dr.
Yeah.
Fanny.
Yeah, I think I answered it. I basically said we use it in the pediatric population, but there's not enough data to support it. However, in cases where we don't have much to offer, that's really a good one to use. So if you're able to use paradoxin and that's all you have, use it, but at most it should be more of an adjunct therapy and not just used by itself. Oh, nice. What else, guys?
Do you have more questions? Or should we send Dr. Ebtisam without asking her? This
Oh
is a
no, please
golden
ask me.
opportunity. Okay. So, of course, you share the slides and I'll share to them and we'll ask questions.
Yes,
And
I will absolutely email this uh PowerPoint deck to Salim and Salim can share with you guys.
that would be wonderful, Doctor.
Yes.
So you don't have more questions? Shall we wrap it up? All right. Today's participants are the silent ones.
It's
Uh,
okay. Do you think that Kepra has? Oh yeah, Kepra definitely has incidents of suicidal ideation. Um, I actually have a personal story about a patient of mine when, so I trained at Emory. So when you train at Emory, it's more of that private hospital setting, but we also go to Grady, which is one of the biggest public hospitals in Georgia. And I had a patient who had a seizure, started having some seizures, so we decided to put him on Keppra, just 1,000 twice a day. And then I think 2 weeks into it, he he had more of a homicidal ideation actually. But it does cause suicidal. He actually tried to kill his wife, and police had to be involved. He was running around with a knife, and we figured it was the Kepro. We discontinued it. Thankfully, nothing happened to his wife, and we were able to exonerate him that this was medication related. So in your patients that have psychosis, history of psychosis, history of depression, anxiety, prior history of suicidal ideation, it wouldn't be the medication I would go for. So yeah, don't use Keppra if patients have suicidal ideation. And then books or PDFs, if I can get my hands on my books from training, I will definitely send it to Salim.
All right, Doctor. Thank you. Thank you. We would like
Okay.
to sincerely thank Dr. Ebtisam Alumin for such a clear, well-organized, and engaging presentation. You explained the topic in simple yet powerful words, and we're so grateful for that. And we will apply what we learned today in our day-to-day activities. So, thank you so much. Before you leave, we would like to take a picture. So, everyone, can you please turn on your cameras and shall we take the picture?
Yeah, let's do it.
Wait. Can we turn off the slides now?
Yes, you can turn off the slides.
You turn it off
I
so I
can
can.
stop sharing it. Yes.
Yeah, thank you.